My study is about retrospective analysis of biometry and its outcome in silicon oil pili undergoing IOL implantation with silicon oil removal. I have no financial conflict of interest to disclose. In today's world, we are heading towards the precise outcome of cataract and refractive surgeries. Silicon oil tamponade complicate the measurement of axial length needed for the intraocular lens power calculation. It is difficult to achieve same precision in silicon oil filled eyes undergoing silicon oil removal and cataract surgeries mainly due to change in the velocity which lead to difficulty in calculating axial length and compromise capsular bag and zonules. Ablation A ultrasound also can calculate axial length, but it is a contact method and it can lead to indentation of the globe, which lead to the wrong axial length calculation and off-axis measurement of axial length by the transducer. IOL master is a fast non-contact method and reported as a potentially more accurate method than ultrasound biometry based on the reflection of interference signal of the RPE. So aim of this study was to analyze the accuracy of biometry in silicon oil filled eyes and to compare the accuracy of partial coherence interferometry with scan ultrasonography. So this was a retrospective method. Data of the patient analyzed who underwent the silicon oil removal with cataract surgery with IOL implantation or secondary IOL implantation between 2013 to 2018. Axial lengths were calculated using either ultrasound A scan, that is OTM machine, or partial coherence interferometry, that is IOL master. For A scan, we use the silicon oil mode, which was inbuilt in the machine, and IOL master with phakic and aphakic mode according to the lens status. SRK-T formula was used for IOL calculations. We included a patient who underwent combined surgery in single sitting, who at least followed up for 3 months, and retinoscopy and refraction was done at the end of 3 months. Silicon oil of 1000 centistroke was used. We excluded patient who lost follow-up post 3 months, who lost follow-up post 3 months and who did not underwent a refraction or retinoscopy, or patient who didn't underwent biometry by the protocol, and the patient who underwent a resurgery with tamponade, we excluded those patients. So 42 eyes satisfied this criteria, and most of the patient, the age group, the mean age was 48.21. Most of the patient was in age group of 41 to 60, and most of the patient, that is 36, were males. The method of biometry was used was IOL master in 30 patients, while A scan ultrasonography was used in 12 patients. Most of the patients were in the group of recombinous retinal detachment. The surgical technique was phacoemulsification in 21, while SICS in 21. The axial length less than 24 were 23, that is 54%, and more than 24 were 19, that is 45%. The IOL design was foldable in 59% and rigid in 40%. So the refractive outcome, the expected refraction and actual refraction were calculated, and the mean of expected refraction in these 42 eyes was minus 0.34, while the actual refraction, the mean was 0.37. The difference between expected and actual was 0.98 diopter in this group. The method of biometry, when we compare the method of biometry in the IOL master group, the difference between expected and actual refraction was 0.71 diopter, while in A-scan ultrasonic group it was 1.63 diopter, and it was significant. When we compare in-bag and sulcus placement, the difference between expected and actual refraction was 0.75 in bag group, and it was 1.8 in sulcus group. While in IOL design, the foldable IOL, the 0.89 was the difference between expected and actual refraction, while in rigid IOL it was 1.1. While comparing the technique of phaco and SICS, the difference was 0.85 in phaco group, while it was 1.09 in SICS group. While comparing the axial length in patient with less than 24 millimeter, it was 0.88, and while patient in more than 24, it was 1.05. So we analyzed the 42 eyes, of which 36 were male, 6 were female, 27 were right eyes, 15 were left eyes. The mean age was 48, 57% were in the group of 41 to 60. The range of expected refraction was from minus 0.84 to 1.33 with mean of minus 34, and the range of actual refraction was minus 3.5 to 3 and mean of 0.37. The range of difference between expected and actual refraction was 0 to 3.58. The mean was 0.98. Out of 42 eyes, most of the patients underwent silicone oil infusion for the retinal detachments. So while comparing the method of biometry, the partial coherence in parameter, the difference was 0.71, while in A-scan group it was 1.63, and it was statistically significant. That and this was seen in also other studies also. When we compare the IOL placement, the in-bag placement, while the patient in which the the IOL was placed in the bag, the difference was 0.75, and in sulcus placement, the difference was 1.8, and this difference was also seen in other studies also. The group, when we compare the foldable with PMMA IOL, phaco with SICS, and myopic and non-myopic eyes, the difference was not significant. So to conclude, the IOL master has more accuracy and less deviation in prediction of the postoperative refractive error than A-scan, and the sulcus placement IOL gives less predictable result than in capsular bag group. To get more insight, the prospective study is needed for this group. Thank you.